Hello and welcome to the Motivational Midwife. I'm Lynn Jones and today we're going to be looking at diabetes. So Diabetes is an endocrine disorder. The body can't metabolize glucose effectively, and that's either because there's an issue with insulin production or the body's ability to actually use that insulin. And insulin, as you might remember, is produced in the beta cells in the islets of Langerhans in the pancreas. So all cells need glucose for energy, and the optimum range for the body to work efficiently is if we can maintain that blood glucose level between 4 and 7 millimoles. So your glucose enters the bloodstream, blood glucose level rises, and the pancreas releases insulin to balance that out, and both the insulin and the glucose gets transported to the cells. So all cells need energy. The brain, you can get energy from various sources in the body, but the brain cells can only really utilize either glucose or ketones. And ketones, there's a payoff for using ketones for energy, and we'll talk about that in a minute. But if you think of cells as being like a locked door, the glucose is there waiting to get in so they can utilize the glucose for energy, and the insulin works like a key. So the insulin opens the door so the cell can utilize the glucose for energy. So type 1 diabetics, these tend to affect younger people, and it's thought to be an autoimmune disorder where the beta cells in the pancreas have been destroyed. So there are no if we go back to our key and door lock analogy, there's no keys being made. So what we have got is plenty of glucose in the bloodstream, but the cells are not able to utilize it because we can't open the doors, we can't let them in. So what tends to happen is the body then thinks it's in starvation mode, and so it looks for other ways of getting energy. So it will start to break down protein from muscle cells into amino acids, and they'll go off to the liver to be converted into glucose, and it'll start to break down fats into glycerol and free fatty acids, and that will go off to the liver as well to be broken down into glucose and ketones. But a byproduct of that is something called inflammatory cytokinase, and they become important in terms of the signs and symptoms that type 1 diabetics can sometimes present with. So these inflammatory cytokinase will often cause nausea, vomiting, abdo pain. And because we've got high blood glucose levels, the body is trying to get rid of that extra glucose. And so the kidneys will try and get rid of it. So some glucose the kidneys will absorb back into the bloodstream, but it's trying really to get rid of that excess glucose. So glucose will also have a bit of an osmotic effect, so it will take water with it. So not only are they weeing more, but because it's taking a lot of water with it as well, they're also very thirsty. So it's that complete cycle of weeing and thirst and weeing and thirst. If you test their urine, it's going to be full of glucose, and that, of course, puts them at increased risk of things like thrush and UTIs. High blood glucose levels really can affect wound healing as well. The lens in the eye becomes cloudy, so vision can be blurred, tired, lethargic, because the body thinks it's in starvation mode. If you think of the Atkins diet, essentially what that was doing was putting people into a ketoacidotic state, so that the body was trying to utilize fat for energy. So because that's being utilised, they often have a lot of unexplained weight loss as well. And that will lead to something called a diabetic ketoacidosis, which really is it's a serious condition and can be fatal. So it is something we really need to be very aware of in anyone who has diabetes. They will often, because of these ketones, the brain can only really utilize glucose or ketones, but ketones, there's a price to pay for using ketones. They're not the most efficient way of having energy. And we know this from labouring women. It's not an efficient use of energy to get energy from ketones as opposed to getting energy from glucose. So ketones are acidic, so they will reduce the pH in the blood. And whilst the blood and the body can buffer a certain amount of that acid, too much will lead to potential cardiac arrhythmias, cardiac arrest and death. So we really need to be on the ball looking at ketoacidosis, and insulin and fluids really are the treatment for these. Then we have our type 2 diabetics, who are probably the biggest bulk of the diabetic population. And really with type 2 diabetics, this is where insulin is being produced, but there is a problem with the cell's really ability to recognize the key. So the keys are there, but the cell doesn't recognize that key is for it. So they're not responding, and they develop something called insulin resistance. So those keys don't open the cells, and therefore the glucose doesn't get utilized effectively. And there's no simple answer to really what causes insulin resistance, but there are some risk factors which we will go into later. But essentially, what it is that those keys can't open the cells. The keys are there, but the doors are not opening, and so the glucose is not getting utilized as it should do. And then our gestational diabetics, this normally happens after about 20 weeks trimester. So this is really people who develop diabetes in pregnancy. And there is some evidence to suggest that if you develop diabetes in pregnancy, then it does predispose you to diabetes at a later point in your life. So let's have a look at diabetes in pregnancy. So estrogen and progesterone, they will stimulate the beta cells. So these are the cells that are in the pancreas that produce insulin. So you will get a rise in insulin and an increase in peripheral glucose use. It will also cause a drop in the blood glucose levels and lower fetal blood glucose levels as well. So as we've said, nausea and vomiting in pregnancy will often upset blood glucose control. And if we don't keep the control of diabetes, the blood glucose level control quite tight, it can lead to fetal morbidity and obviously for the mother, hypoglycemia, so that low blood glucose levels. So initially in pregnancy, the insulin requirements do decrease, but they gradually rise again. And for diabetic women, their insulin dosage will be adjusted accordingly, which is why it's important that really they are cared for by a joint team of the endocrinologists and the obstetric team. And many trusts will have a joint clinic. Certainly at the trust I work at, we have a joint clinic. So we have a joint diabetic clinic. So both teams are there present together, and they see the woman together. So therefore she's not having separate appointments, and also both sides know what each other is saying. And as we said about the cloudiness, the lens becoming cloudy with the high blood glucose, so pregnancy itself may accelerate that process, and if they get kidney disease, which if you've got a long-standing poorly controlled diabetic and they have kidney disease, it's going to increase that risk of growth restricted babies, preeclampsia and preterm babies. Okay, so our increased insulin resistance. So essentially, some of the pregnancy hormones, when we talked about type 2 insulin resistance, there's a similar thing going on here in pregnancy, in that the pregnancy hormones actually make the cells slightly insulin resistant, so it alters how the glucose is metabolized, and beta cells will produce more insulin. Okay, so our pregnancy hormones increase the resistance and alter carbohydrate tolerance. Okay, so what that will result in is more glucose and amino acids going to the baby rather than the mother. And that will stimulate the baby to increase insulin production, and that itself stimulates fat and glycogen deposits, so the baby, and that acts as a growth factor. So if we are not got well controlled diabetics, so that will result in your macrosomic baby, and your increased risk of hypoglycemia in the baby, as once it's born, those high sugar levels will have disappeared. Okay, our gestational diabetics, there's variable severity of carbohydrate intolerance, and the onset or recognition of gestational diabetes is obviously in pregnancy. So there may be no other signs of diabetes until she is pregnant. She might have an abnormal glucose tolerance test following pregnancy. And it might be normal following pregnancy. Okay, so during pregnancy it's an abnormal GTT, but once the pregnancy is over and she has a repeat GTT, it's absolutely normal. It may well be that she's an undiagnosed type 1 or type 2 diabetic, and as I said, there is people who have gestational diabetes have an increased chance of developing diabetes later in life. So it usually shows itself sort of 20 to 24 weeks. And that insulin resistance, the body is converting fat and proteins into glucose. So we're going back to that sort of starvation mode. And they will then have high urea and ketones. Blood glucose will be high, ketone urea, protein urea. So these are sort of signs and symptoms they may present with. So our risk factors, family history, we've said. If they have got an impaired glucose tolerance test, so anyone who is really at risk of diabetes should be offered a glucose tolerance test, and that often that's earlier in pregnancy for someone who's maybe much higher risk, but generally certainly at between sort of 26, 28 weeks, you would expect them to have a glucose tolerance test. Previous gestational diabetes, so if they've had it in a previous pregnancy, they're more likely to get it again in this pregnancy. Raised blood pressure, we've said. I think I'd put under 35 when it should be over 35. Increased BMI, we've spoken about. Previous big babies, and this over the 4.5 kilos, and this could be because there may have been an undiagnosed gestational diabetes, and that might have been a slightly macrosomic baby. Any babies with any fetal abnormalities, because certainly uncontrolled diabetics are much more at risk of having fetal abnormalities, and obviously their family origin. So there are certain ethnicities who are much more likely to have diabetes in their family. Certainly some of the more Asian cultures are more likely to develop diabetes. So diagnosis would be urinalysis. So you'd expect glycosuria if you were doing a random blood sugar result of over 6.1 millimoles, or fasting over 7 would be indicative of gestational diabetes. And say glucose tolerance tests somewhere between 24 and 28 weeks, particularly if their random blood sugar is of those levels, they would be offered a GTT to confirm. And if they've had a previous gestational diabetic pregnancy, then they'll probably get screened slightly earlier. So your GTTs over 7 or over 7.8 after 2 hours. So management, ideally, as I've said, joint care with your diabetic and your obstetric team. Diet and lifestyle advice, ideally from a dietitian. Some may be put on oral medications such as metformin or glibenclamide. Metformin tends to be the one I've seen used the most. And some of those medications, they all work slightly differently. Some have an effect on carbohydrate metabolism, some increase insulin production. So it depends. Individualized care, regular scanning, really, because we're looking at fetal growth as well here. And blood glucose monitoring, ideally we're trying to keep them between 3.5 and 5.9. So remember we said, in an ideal world we want between 4 and 7. We want a much tighter control with pregnancy because of the potential implications for the baby. And you're looking at 7.8 after an hour after they've eaten. Now, your HbA1c is a blood test that is done, which gives you a longer, really how their diabetic control. So they might be telling you that their blood glucoses have been absolutely fine, but when you get their HbA1c back and it's not within a normal range, you know that actually it's not been fine, because this gives you a longer picture of what their longer term diabetic control has been. So in terms of labour and birth, well, obviously, top of that really has to be woman's choice, but she should really be informed of the pros and cons of all her options. Ideally, within an obstetric unit where you have got recourse to continuous CTG, which would be recommended. But again, all of these things are down to women's choice. There is an increased risk, as we have said, of stillbirth, particularly latterly in late pregnancy. So often these women are offered induction of labour around 38, 39 weeks. In labour, hourly blood glucose monitoring, and if their blood glucoses do go above 7, then usually they will be put on a sliding scale. So that's a mixture of insulin and fluids, and the insulin will be titrated depending on what her blood glucose levels is like, trying to keep it at an optimum range. There is an increased risk of shoulder dystocia if we've got a macrosomic baby on board. Postnatally needs to be really individualised care, and it's important that we do undertake observations. Well, depending on whether she is a pre-existing diabetic or whether she's a gestational diabetic will depend on how frequently blood glucose monitoring needs to be done. Very often with a gestational diabetic, post-delivery, it's often 1 or 2 blood glucose monitorings for the mother, and if they're normal, that's it, and then she will have follow-up with the GP. But obviously, if she is a pre-existing diabetic, then she'll go back to her pre-pregnancy regime. But again, follow-up should be with her existing diabetic team, and so close liaison with that team is important to make sure that she goes back onto her the regime that is normal for her. So referral, obviously, again, as I say, to her obstetric team. Now, from the baby's perspective, really, we're looking at this baby. We're concerned about risks of hypoglycemia for the baby. So blood glucose monitoring. Usually it will depend on your trust policy, but certainly 2 or 3 pre-feed blood glucose monitoring for the baby. And you are in a term baby, you're looking at above 2 millimoles or 2.5 millimoles, depending on your trust policy. And baby observations, because remember our energy triangle, we've got glucose, oxygen and temperature there, and any one of those is going to affect the other 2. So if we have a baby that is higher risk of hypoglycemia, it is also likely to become hypothermic and also hypoxic. So we need to keep a close eye on that baby. So undertaking a full set of observation on the baby, certainly post delivery, and then at a frequency that is within your trust. And then document everything, obviously. And there you have it, diabetes. I hope you found that useful. If you haven't subscribed to the channel already, please do so, and look out for us on Facebook at The Motivational Midwife.